Good afternoon, everyone. As you've heard, my name is Caroline Tigoi from Kenya. I'm going to present to you on, you can hear me? No sound. Oh, that's good. Yeah, I'm going to present to you on my work on acquisition, persistence of extended spectrum beta-lactamases and carbapenem resistant E. coli carriage among hospitalized children in Kenya. This work was done in collaboration with the University of Oxford and the Sanger Institute. So as we all know, AMR acquisition and loss may be important drivers of inpatient and post-discharge mortality, especially in the low middle-income countries. And extended spectrum beta-lactamases and carbapenem resistance are a mode of resistance that cuts across a broad class of antibiotics. So if we have resistance to these classes of antibiotics, that it means it renders the antibiotics that we've had over time ineffective for treatment of common infections. And these resistance genes are spread via mobile genetic elements intra and within species. And for this project, we hypothesize that we know that the gut is a reservoir for most of the bacteria, and therefore intestinal carriage would be the mode of transmission of AMR and invasive and a precursor to invasive disease. So under 5 mortality remains high, but it has been steadily decreasing. And a recent study that was done by the CHAMPS network showed that Klebsiella pneumoniae, E. coli, and other multi-drug resistant bacteria were in the causal pathway of about 87% of deaths in children, and also some of the global neonatal sepsis that was done, seen in another study, 1/3 of which were attributed to AMR. So AMR has been linked a lot to, or attributed to mortality, especially in young children. So this study was done within a bigger project that is called the CHAIN network, that was done in Asia and Africa. And the aim was to look at the causes of mortality in children. And the outcome of interest was mainly mortality, readmission, and nutritional recovery. So for this study, the carriage study, we collected rectal swabs at different time points, admission, discharge from hospital, and then followed them up to 6 months post-discharge from hospital to understand and characterize the acquisition and loss of ESBL and carbapenem resistance during admission to hospital, and then at discharge from hospital, and then follow up post-discharge from hospital. And the main aim is to understand the effects of hospital environment and effects of antimicrobial treatment as you receive antibiotics in hospital, because we've known that most of the time when children come into hospital, they come in with less resistant bacteria. Then because they get exposed to antibiotics and because of antibiotic selective pressure, and then exposure to contaminated hospital environment, then they acquire resistant bacteria that is then transmitted to other children that are susceptible. So this study was done in 3 Kenyan sites across all the time points I've mentioned. We included 804 admitted patients and 405 healthy community controls. So we had a control group that was from the same vicinity as the index admitted child who was included in the study. So phenotypically, we see that there is carriage of AMR, ESBL specifically in the community, about 20%. And those that are coming into hospital at admission was still carrying about 40%. Then there is a huge rise in hospital because of exposure to the hospital environment and because of use of antibiotics. Then this declines to almost community level at 6 months post-discharge from hospital. But then the urban site, which is Nairobi, remained high. And we find that readmissions also was still carrying this ESBL and at a quite high rate. Same for carbapenem resistance. At discharge, Nairobi remained high, and also for the readmissions. And we were quite worried about the carbapenem resistance because it's the last line antibiotic that we have. Again, looking at association of carriage of this ESBL with post-discharge mortality. If you acquire, you come in negative at admission, and then you acquire ESBL, then you are at higher risk of mortality or being readmitted. So we did whole genome sequencing for all these isolates, and mainly focusing on E. coli because, as we said, transmission of AMR is based on mobile genetic elements. So it doesn't matter which bacteria you're looking at. So I focused on E. coli to look at, to characterize the presence of these AMR genes and also mobile genetic elements. So for us to understand the diversity of these and relatedness of E. coli, we did whole genome sequencing, both Illumina and nanopore, and then did quality control of all the reads and phylogenetic analysis to look at the relatedness at gene level, mobile genetic element level, and also at strain level. So this is a phylogenetic tree that is showing the relatedness of the E. coli. I had both invasive E. coli from blood culture, environmental from swabbing the hospital environment, and rectal swab as well. So the orange in the inner ring shows the rectal swabs. The blue are the available blood culture isolates that we sequence, and also the red are the environmental swabs. So what we saw is that the E. coli genomes were quite diverse. So the outer ring shows the site. So they are found all over, distributed across Kenya. And the phylogroups groups that we were able to identify were 12 out of 14 that have been identified globally. Some have been associated with invasive disease, and the innermost ring here were the sequence type. And what we found was that most of the predominant ST types were ST38 and 131, and these have been associated with invasive disease. But based on the hypothesis that AMR carriage in the gut is a precursor to invasive disease, as you see, some of these blue bars here shows that some sequence types actually cause both invasive disease, and they are also carried in the gut, which means that at some point these sequence types can cause invasive disease. So our hypothesis could be true. Looking at the virulence genes, so these are heat map that is showing us the virulence genes, the sequence types, and the different AMR genes. And of interest, or what was striking to us, was the sequence type 167, which was carrying carbapenem resistance. If you can see from here, I don't know if my pointer is showing. So yeah. So this was an NDM carrier, and it's been shown by other studies. Similarly, ST69 also carries mainly ESBL, and ST131 is a multi-drug resistant sequence type that was found to be circulating in Kenya, which agrees with what other studies have also found. We were also able to find most of the AMR genes, and because the study was looking mainly at ESBL, the most predominant for ESBL was beta-lactam CTXM15, and for the carbapenem resistance is the NDM5, which was common in our setting. Looking at this carriage of these AMR genes longitudinally, the most predominant was the one in blue, which is beta-lactam CTXM15, circulating across all time points. One of these, the pink one, CTXM169, was mainly acquired in hospital, but still persisted across all the time points. For the carbapenem resistant genes, we had mainly the NDM5 persisting across all the time points. For the sequence types, as mentioned earlier, ST38 and 131 were the most predominant, but some were more predominant in the community, like this one, ST636, mainly found in the community. And there was one that was mostly acquired in hospital, which is this ST167. And we had an unknown ST that was circulating in the hospital environment. Looking at the plasmids, so we typed plasmids using MobSuit, and the most predominant plasmids that we see in our settings and that have been associated with AMR within the Enterobacteriaceae family is the INC-F type. So think F were the most predominant. And we also classified these plasmids as whether they were mobile or non-mobile because it has public health significance in terms of transmission of AMR. And most of them were mobile. The mobile ones were mainly the large and the medium size. Very few small were mobile, and they were carrying the AMR genes across all the classes. So we should be targeting them for infection control. So in conclusion, we've seen that the significant AMR acquisition in hospital before and even during hospitalization. The AMR, the E. coli genomes were very diverse in terms of sequence types, the phylogroups and ink types. They are found all over. So it means if we are developing a vaccine, it should be looking at all the sequence types, or maybe focusing on the proteins. And carriage of some of the sequence types, as we've seen, were also clinically significant because they cluster with the carriage isolates ones, and therefore, the carriage in the gut is a precursor to invasive disease. We've seen that there is association of AMR with mortality and readmission. And some of the recommendations we've been making is to do risk stratification of patients when they come into hospital. If they are not severely ill, then they should be discharged earlier to avoid acquisition of nosocomial infections. And it's something that has led even to a study, clinical trial that we are doing to look at how we can do the stratification and discharge children earlier. And also we are participating in some of the vaccine and probiotic studies looking at maternal vaccine on Klebsiella pneumonia and E. coli. Thank you very much. I would like to acknowledge the chain network and my supervisors, mainly Jay Buckley and Trevor Lolly at the Sanger Institute, and Nicole Streiser at the University of Oxford. Thank you.
Thank you. Good presentation. I saw on your phylogenetic that you have environmental sample.
Yes.
What type of sample? Was it from water, or was it from chicken market or something else like that?
It's hospital environment, so we are swabbing the baby coats, the maternity tables, the beds, walls, and the floors in the hospital where the children were enrolled from. Yeah. So there are quite few E. coli in the hospital environment.
Got a question over there?
Thank you so much. So I'm just looking at the tree and then I'm miscrewing. Like, did you carry out combination analysis on the alignment? Yeah, before you place the tree, did you try to remove combinants?
I didn't do that step.
Yeah, you say the person wait.
Yeah.
So if you look at the tree,
Yeah.
so that some are sitting on a very long branch. Yeah.
Okay.
So it's gonna that is what the combinants do. Yeah, to your tree. So it's important that you do. We always do that. We always put combinants from bacteria and from viruses. So you will need to do that. That will make the tree look much more.
Okay. Thank you for the feedback. Yeah.
Thank you. Are there